Good morning, everybody. I'm very glad to welcome you here in Paris for the 10th edition of the Brain Metastasis meeting. As you know, we could not make it last year due to the sanitary crisis, and I'm very glad that you could come in this particular period, and I really want to thank you all for coming. Today I feel honored to introduce Dr. Adler, that has the opportunity to come. Dr. Adler is professor of neurosurgery in Stanton and is also the inventor of the CyberKnife and the Zapix, and I'm sure he has a lot of tell us about the evolution of radiosurgery. Last precision, due to this peculiar period, the meeting is in hybrid fashion, so we have some people on streaming, and we will have to be very careful to the time of the communication during all these 2 days. So thank you, Dr. Adler.
So I have spent much of my life dealing in the world of stereotactic radiosurgery. And last night, Manfred, is Manfred here? Hey, Manfred. So Manfred sort of targeted some of his discussion last night at me, thinking that maybe in some way I don't believe in the power of a scalpel and what can be done with traditional neurosurgery, and that's not true at all. I mean, I spent much of my life in the operating room taking out tumors, but there's a lot of things we can't do. And I think what we've realized over the last generation is the power of precisely targeted radiation or stereotactic radiosurgery. And having been swept away by what radiosurgery could accomplish when I was very young in my career, I became convinced that it was the future of much of surgery, and hence my own interest in the field. And yet, as you're going to show you, no matter how almost near miraculous the outcome are with stereotactic radiosurgery, the vast, vast majority of patients today are not getting it. And it was with that realization that led to this latest project, Global Access to Stereotactic Radiosurgery. And this is especially relevant to brain metastasis, which are certainly so prevalent in the world today. So all of you have witnessed outcomes like this after stereotactic radiosurgery for brain metastasis, or at least I suspect most of you have. And if you compare this to almost anything else that's happened in modern medicine over the last 30, 20 years, it is truly near miraculous. And I compare this to the greatest achievements of modern medicine. I mean, genetics, mRNA vaccines, TAVR, replacement of aortic valves. I mean, this is immunotherapies. This is truly outstanding. And yet it's been a very quiet revolution. And it should be celebrated. And, but the sad reality is that when we look around the world, we realize that about 2, 3, maybe 4 million more patients every year would benefit from stereotactic radiosurgery if they had it. And our best count is that less than 200,000 patients. And I'm not talking about sub-Saharan Africa. I'm talking about Europe and probably rural France and certainly parts of America, and of course places like Russia and Brazil and China. But 2, 3, 4 million patients a year don't have access to treatments like this. I'm not alone in observing this inequity of radiosurgical availability. Jason Sheehan, a neurosurgeon at the University of Virginia, he surveyed the world and looked at it in terms of gamma knife units. Nothing wrong with a gamma knife. It works well in many circumstances. That's where I started. But what he could show, very convincingly, is that you look at North America as a benchmark, the vast majority of the world is underpopulated with stereotactic radiosurgical facilities. And this has been looked at with linear accelerators and other technologies as well. There is an inequity in the available radiosurgery today around the world, and the impact is millions and millions of patients, millions. Now, some of you may not appreciate it because you're here in Paris and maybe you have access to good radiosurgery. But for much of the world, that does not exist. So the question is, you have this miracle of modern medicine, and yet the vast majority of patients are not being treated. So maybe it's not a miracle. Maybe there's some other reason it's not being used around the world. Well, if you think about stereotactic radiosurgery, you realize there's good reasons it's not more available. For example, the gold standard, the Gamma knife, uses radioactive cobalt, which the world is trying to get rid of. You know, in a good world, we wouldn't have any radioactive cobalt. It's just so intrinsically dangerous. But then there's other reasons as well, because the single most complex and expensive medicine today involves stereotactic radiosurgery. Can you think of anything that's more complex and expensive? Maybe protons, carbon. I mean, there's always a way to be utterly insane, not just insane. But it is so expensive, so complex. And then there's lots of control siting issues. The machine has to go into these big radiotherapy vaults traditionally. That's a problem. If you don't have a vault, you don't have a machine. Operator can't treat safely. So for these reasons, I'm going to submit cost, complexity, and ultimately the control. And surgeons who control a lot of the patients have no access to radiosurgery. It's just easier for them to go to the operating room and take out a tumor. If Manfred had a radiosurgical machine right next to his operating room, I assure you he'd be doing more radiosurgery. Just how the world works. It's a practical matter. So with those issues in mind, I set out to make something new a few years ago. And that's it, and we're going to talk a little bit about it and kind of hopefully why it may help treat more patients that are currently being treated today. And this is the ZapX. So it's the first of its kind self-shielded therapeutic radiation device. So I could literally put it right here in this room if I wanted to. It doesn't use radioactive cobalt, and it is really designed to be much simpler, lower cost, and really it's optimized just for the brain and head and neck. So many of the technologies developed, my CyberKnife included, were compromises. I needed to treat the brain, I needed to treat the prostate, I needed to treat the breast, the lung, whatever. And if you can only have one machine, you don't see many patients, and that may be the right solution. But for the huge number of patients need to be treated, an optimized platform that lets us treat these patients better and faster made a lot of sense. So this is the first time anyone has ever made a vault-free therapeutic radiation device, which I think is kind of a meaningful accomplishment, but the kind is not a technological one. It's the enablement now of putting radiosurgery where patients are, and hopefully allowing more of these 2, 3, 4 million patients each year to be treated. And what we're seeing in many locations is, private practice of doctors can get together, they can own their own machine, they don't need the hospital anymore because it is far less expensive than what currently exists. So this is my good friend Alex Milosevic in Munich. So you can see, he's got really one of the busiest CyberKnives in the world, busy enough that he needs some more capacity. And so right now, this is front and center. The people walk down the street in Munich and they go, oh, what's that? It's like a time machine. So I tell you, it is a time machine. It takes you back to the time before you had your brain tumor. So here, this is what's being built in Loma Linda right now. Someone's even putting one in a Shinkansen station, a fast train station in Japan. So, radiosurgery is now going to be much more available. And not only can you see, the world is going to finally recognize that this revolution, which many of us has touched our practice life, is now going to be much more available to patients conceptually, and even physicians. I mean, I would say 3 out of 4 physicians know little or have never seen, know little about or have never seen a modern piece of therapeutic radiation equipment, much less stereotactic radiosurgery. So part of the reason this quiet revolution is so quiet. And I'm going to show you why this revolution is just getting started. We're not at the end of this revolution. We're in the early stages. So this technology does use a linear accelerator, no radioactive cobalt. And so it delivers radiation very effectively, very quickly. And yet, as you'll see, the energy is optimized for the brain and head and neck. So you get the steepest dose gradient. The more powerful the energy, so you get different energy of Linacs. You can have, this is 3 MV, but commonly we use 6 MV and even more. And as the photons go in, they scatter, they shoot from, and when they scatter, they blur the edge of the radiation. But by using this energy, you concentrate the radiation more effectively in and around the tumor. And everything's been designed and optimized. You'll see it's like a gyroscope. There's mechanical elements, and it lets us shoot from more directions. More directions are how we concentrate the radiation more effectively. So the more angles of attack, the steeper the dose gradient. The steeper the dose gradient, the less normal brain you treat, the more concentrated you can make the radiation inside the tumor. And so we measure this by steradians, and so in the dream case, it would be 4 steradians. If you cut off the head and put it on a little stick, then you could shoot radiation from even more directions, and that's how you concentrate the radiation optimally. But fortunately, we don't cut patients' heads off. But the idea is to leave the shoulders where they are and to treat as much as you can. And that's what we've tried to accomplish with this kind of technology. So the energy, as I implied, it's lower energy to allow the radiation less scatter and therefore be more concentrated in the tumor. And then the collimator, this whole marvel, is to block out all the scatter radiation. So just this pencil beam of radiation, the kind of the proverbial surgeon's knife, is all you're dealing with. And that's pretty much what's been accomplished with this huge tungsten collimator. And then lastly, by putting the target closer, the target of the radiation device closer to the target in the brain, the tumor, the steeper the dose gradient again. So all these little tweaks at every level has been done to sort of maximize the dose gradient, the sharpness of the knife, proverbial knife, inside the brain. And so what does this kind of mean? It means that you can get the steepest dose gradient possible. I don't know if this laser pointer doesn't work, but there's 3 different curves in each one of these graphs. The outermost one is the CyberKnife, the red one. The blue is the Gamma knife, and the green is the ZapX. And you can see in the 3 cardinal directions, the ZapX has the steepest dose gradient, and therefore, again, sort of the sharpest proverbial knife with this kind of 4-millimeter collimation. And this is particularly, the steepness of gradient is especially needed when you treat small and smart targets, which is progressively where the world is going, as I will show you at the end of this talk. So collectively, we've done many little things to try to optimize the treatment of brain, head, and neck tumors. So we can argue what we have today is good enough, but what you're going to see here is, well, why not try to do better? And it's going to be better because you all know patients with brain metastasis, and that's what this conference is about, come back for multiple sessions now, not uncommonly. And so what matters with each and every session is not just did you get the tumor, but also how much of the normal brain got irradiated as well. I mean, there are some VMAT linear accelerator solutions today that basically do radiosurgery to the brain, but give such a high integral dose to the normal brain that you preclude future radiosurgery. And so, as a general premise, the less radiation you give to the normal brain, the better. So take that as a tacit assumption underlying this work. And so here, this work comes from the NHS. A guy named Ian Paddock, a radiation physicist, and kind of is obsessed with the idea of getting radiation as concentrated as you can inside the tumor. Well, he was tasked by the NHS to kind of look at the different radiosurgical platforms in UK and say which kind of meet a stereotactic radiosurgical threshold and which don't. And he plotted these out using something in the R50%. And then plotted out, so these are a series of different demonstrative cases that were planned with these different systems. And he then looked at the threshold of radiation and the gradient and see how much normal brain was spared in each one of these scenarios. And then he developed a couple curves here. The bottommost curve is the Gamma knife. And the ideal curve would go right across at 1. We don't do that. But the closest approximation was the Gamma knife. And that's that bottom curve. And then the CyberKnife was a little bit above that. You can see the different scatter plot points there. Then the other range of different linear accelerator systems kind of have a more steep slope curve. And then some things like tumble therapy were just kind of scattered kind of randomly. But you can see, come away with this and you say, hey, the Gamma knife, based on this measure of dose concentration, is the best technology. We then took these cases and planned them with the ZapX. And because of the little things I was pointing out, it had the best of the best. So the idea is to, in this new world where we don't want to treat normal brain with radiation, to do the best. As Lars Lexell would say, you know, when it comes to the brain, no technology could be too refined. And he, of course, invented the field. So where's this relevant? Well, this is why it's relevant. And these are the kind of cases you're seeing in your clinic. When you start having multiple brain metastases, there's overlap dose between adjacent tumor, and that overlap dose is what precludes or complicates future treatment when they come back for their second, third, sometimes fourth or more. I've seen patients with hemangioblastomas in my own career come back as many as 9 or 10 times. So better dose gradient means a lot, and yet still what you'll find is relatively efficient treatments as well. So here's something we're seeing now. We now believe, based on the Chang data out of MD Anderson and subsequent data as well, that whole brain radiotherapy is not good for your brain. The fact that it took, I was 25 years in my career before someone could definitively say that shocks me, but that is, I think, almost accepted now as truth, that you want to spare the normal brain. And so when you get 17 brain mets, case in point, it could still is best to treat them with stereotactic radiation, especially when you know a patient like this may well come back in 6 or 9 months or a year with even more brain mets. And yet again, perhaps in subsequent years. And even Manfred, no matter how skilled a surgeon he is, he's not going to be able to do cases like that. You'd need stereotactic radiosurgery. Whether they be small metastases or more complex metastases, here, you know, in the back, the posterior fossa, close to the brainstem, where, again, relevant dose gradient is incredibly important, because if you misjudge the amount of dose going to the brainstem, you will turn a great palliative case into a disaster. And in many cases, a good surgeon can't undo the damage that you've done to the brainstem. So dose gradient is critical, and yet you give up nothing. These are relatively quick cases. As fast as Manfred may be in taking the tumor out, and I am too even, nothing beats radiosurgery. These are 15, 20, 30-minute cases in even the most complex situations. So just to recount a little of this technology and why it accomplishes the dosimetry I've just alluded to. Well, the mechanics are very novel, and I've already alluded to it, and I'll show it to you again in a brief video. But you've got this one big bearing, so standard linear accelerator, which most of you know about, just has a single bearing, just a single axis. And it allows you then, by rotating the table, to get most angles to shoot at from the tumor. But here, we get not just one big rotational degree of freedom, we get a second. And there's these, we call it the oblique axis. And there are a total of 6 degrees of freedom in this surgical robot, this radiosurgical robot. 6 degrees of freedom, and that's how we get that dose concentration. And yet we do this in a way where all the critical components are housed on this big steel dome that rotates with the patient and then contains the radiation so that we don't need a radiotherapy vault. And while this may look claustrophobic, it actually is not, because it opens up inside, and having treated hundreds of patients at this point, we know that pretty definitively. So as a robot, everything moves. The table has 3 degrees of freedom combined with those 2 big rotational degrees of freedom. And it all moves with incredible precision, less than 0.1 millimeter displacement from where we think it's going to be. And then we have this targeting, which is very much CyberKnife-like. A camera, an X-ray source, which rotates around the patient, and from different angles makes projection images and correlates them with the patient's CT anatomy. And then the collimator and the linear accelerator, which we talked about, are paired with a detector. This MV detector measures transit dosimetry. And there's no country for which this is more relevant than France. So some of you have been around long enough to know that a little over a decade ago, there was a very unfortunate accident or two here in France. It was very quietly dealt with, but several hundred patients were mistreated in the setting of stereotactic radiosurgery. And no one did this willfully. It was a mistake because this technology is so complex and the calibration wasn't done quite right and the vendors didn't talk with each other. But in the end, it led to the death of many patients. And it's not just France. This thing has happened in America in many locations. There are being very quiet lawsuits in America. America does everything with lawyers, and many tens of millions of dollars changed hands, and quiet. But occasionally it leaked into the newspapers. It's happened in Japan. And who knows what's happened in places like China or Russia or Brazil. The point is, now we will know what dose of radiation is being delivered to the tumor while it's being delivered. And someday maybe we'll even prove that we've hit the exact spot. So when a surgeon cuts with a knife, he gets feedback. He can feel how deep the knife is going. He can see with his eyes where it is. So that's the proverbial way that this robot works. You can see where the dose is going. You can sense with your eyes that the right dose is going to the right place. And this is good because we won't have problems like we've had in the past, but it also gives more doctors the confidence to offer this procedure so that we can treat more of these 3-4 million patients a year who don't have radiosurgery today. Keep reminding yourself, most of the world is not getting treated with radiosurgery, and this is part of the reason why. Treatment planning is a problem. Treatment planning in the world today involves pull-down menus and submenus and submenus. It is a specialty unto itself. People take months to learn how to use a treatment planning system. It is so complex that even the specialists don't understand it. So what we try to do here, and Mohan, that guy over there, is a genius. He took kind of Silicon Valley sensibilities to say, well, we want almost everybody to be able to do world-class treatment planning. Let the software do the hard work. Instead of using kind of sub-menu systems that were created a generation ago, make it fresh, make it look like an iPhone app. And really, most all of you, give me an hour and I can teach you how to treat on the ZapX. It's almost that simple. But we don't want everyone to know because they'll cut the reimbursement, right? So anyway, so now we can change the size of the beam, the aperture of the beam, literally in a second, anywhere from 4 millimeters to 2.5 centimeters. And we may be embarking on yet another aperture here size as small as 2 millimeters. And I'm going to show you why that might be relevant. But very quickly, we can change aperture size, give you more flexibility, give you, again, better dose gradient, give you more effective treatment because you have a sharper knife. For those of you who do CyberKnife, you recognize this kind of paradigm using projection X-ray images correlated against the CT scan with digital reconstructed radiographs. That correlation process has now treated millions of patients. We know it works. But this is done quite differently because we're only using a single imager and a single source. But it delivers sub-millimeter targeting accuracy without a stereotactic frame. Again, making radiosurgery faster and more convenient. Radiosurgery should just be a few-minute procedure. And right now, the machine you're looking at is a point-and-shoot machine, right? We go, shoot a dose, we move, point, shoot, move, point. But eventually, you can see that with the device that we're making, we'll just move in arcs. So what is today might take 30 minutes, some days it's just going to be a few-minute procedure. Think about how just most everything, all your BRAINMETS are so simply treated. Once you get rid of the frame, once you just speed up the process and optimize it for brain metastasis, because that is why we're here today. And here's lastly, that transit dosimeter, which allows you real time, for the first time ever, you can record the dose you're delivering through the head. There's no guesswork, there's no calibration problem, it is real. And this safety feature is going to enable this to be done in many more locations than is currently possible. When you're here and in Paris, maybe you have the world's best physicist, you feel good. But if you don't have the world's best physicist, you need to be scared sometimes, and rightfully so. But no longer. This is now your world's best physicist. There to make sure you're always doing the right thing. So this is the company I had to start. We're in Silicon Valley. If you have an idea, it's incumbent on you to start from scratch, and that's kind of what we did. But Varian helped us get started, and as did Foxconn, which makes a lot of the consumer electronics you use. And right now, this technology is available in much of the world, and hopefully China by the end of the year, because China is such a big place in the world. And we have 7 of these machines installed to date, 3 in Europe. Some are coming to Paris even in the next year. So I hope you have a chance to learn more. So these are where our machines are going in the near future. Trying to treat again, let's focus on the fact that there are these 3-4 million patients a year who don't have access to radiosurgery today. So, I mean, this is a new concept. And it's new because we need to fix the problem of not treating enough all the patients who would benefit from radiosurgery today. Again, this is not a Paris problem per se, this is a world problem. By making something that doesn't require radiotherapy vault for the first time, we open this up to siting this machine in new locations. And in America, a lot of these are going into the community practices, where neurosurgeons see a lot of patients. They haven't the wherewithal to refer these patients outside, or the access to the technology. They have some radiation oncologists they work with who comes help them support them, and they're treating patients effectively each and every day. And from the ground up, we tried to optimize this technology just for the brain and head and neck. Much of the radiotherapy industry is about multi-purpose, I call Swiss Army knives. That Swiss Army knife, you have Swiss Army knives in France, I assume, but you can cut a fish, you can clean a fish with it, you can have a little scissor, you can clip your nails, you can have a bigger knife, you can cut some rope, but none of those are optimized. If you are a sushi chef, you want the sushi knife, okay? You're a surgeon, you want the scalpel. And so what we've tried to do is optimize just for the brain and head and neck, because that is such a highly delicate area of the anatomy to be working with. And so for every attribute, we've tried to make this easier to use and also, at the same time, less expensive, to open it up to the world at large that does not have access to this technology today. So briefly, here's a little video that'll just walk you through what I've just tried to talk about. So it is dramatic. It is intended to be dramatic because we want radiosurgery to finally be recognized by the world, especially now that you can take it out of the vault. My dream is to put one in Times Square, New York. I want to compete with Broadway. So Champs-Élysées would be a good place as well. So the idea is that the patient goes entirely in this machine. It contains the radiation, so the operator is not unduly gets a general public dose of radiation, gets a dose of radiation that has, as far as we know, no health consequences at all. The collimator is just a marvel. It blocks almost all the scatter radiation so that all you're dealing with is this pencil beam of radiation. You'll see a couple windows that actually look in and out of the machine, so an operator can watch the patient being treated from literally a meter away. And we changed this aperture size in just less than less than a second, which gives you lots of flexibility, again, to concentrate. Radiosurgery is about concentrating the radiation in the tumor. And whether it be a big brain metastasis or a non-brain metastasis, it's all relevant. And the CyberKnife people recognize that digital reconstructed radiographs, the DRs, which allow us to target accurately, everything moves here. So it's a robot. We're entering a world of robotics. As Manfred pointed out last night, we're all going to be replaced by robots soon, right? Maybe not, but aspects of it will. So the movements is, again, these 2 degrees of freedom define the rotational degrees of freedom that are quite impressive when you see them in person. And when they move together, they give you the opportunity to crossfire from more directions than was previously possible. And that crossfire is what gives you the steeper dose gradient, that a proverbial sharper knife. This is the solid angle coverage. And we do this with point and shoot, but I reiterate that someday we may just do this in arcs, so that all this happens 2 or 3 times faster than what you're seeing here. And because they're literally, in a few minutes, you should be able to treat each and every tumor. And that allows us to treat these multiple brain metastasis patients faster than ever. And lastly, this is that dosimeter that records the transmitted energy to ensure that what's delivered is what the physicist told you was going to be delivered. and provides a measure of safety that will prevent the rare but occasional problems that we've had in this industry in the past. These are really the only real problems we've had in the radiation industry in the last 30 years. So here's what these new facilities look like. They're intended to be visible to the world. We want the world to know about radiosurgery and to ask for it. So there's even a little bit more of a future. While oncology is a big unmet need and we're all here today trying to do better for our patients, if there's a depressing area of medicine today, it is in the psychiatric domain. If you ask the World Health Organization, what are the biggest problems in healthcare today? Like 4 out of the top 5 are all psychiatric problems. Things like addiction, chronic pain, depression. These are the huge unmet needs in our society. And we've, actually I don't have the right, I had an image here of Alim Benabid, who some may know from Grenoble, but I guess it's an older presentation. But nevertheless, Alim Benabid, a neurosurgeon in Grenoble, who may win a Nobel Prize someday, I hope. I nominated him a few times. He has showed us that by implanting electrodes in the brain, certainly for Parkinson's disease, you can reverse these functional disorders. That radiation, well, he has shown that electricity can inhibit these brain circuits that underlie these type of diseases. And that's, a monumental achievement. And now we're increasingly showing that deep brain electrodes can interrupt the pathologic circuits that underlay a host of other diseases. Things like addiction, even obesity, have underlying pathological circuits that cause these conditions. Well, the whole question is, if this is really a modern approach to the way we're going to treat behavioral diseases, can you really envision treating 1 billion patients in the world with electrodes in their brain? It seems kind of over the top, invasive, and maybe not necessary. So we have been pushing, I've been pushing now for several years, and the company is now pushing, the idea that radiation, this tool that you use to treat tumors, that doesn't just kill cells, but it can also change, alter the sensitivity of a brain circuit. So imagine for a disease like addiction, it's just a thermostat. With the right dose of radiation, you can just turn down that circuit. Now, what is this? Seems kind of strange. I mean, is that what radiation does? Well, actually, you've seen it happen. Anybody who's seen a patient with whole brain radiotherapy has seen how that brain works less and less well. Whole brain radiotherapy is a form of down-regulated neuromodulation. If you've ever treated a case of trigeminal neuralgia with radiosurgery, you've seen it happen almost instantly. Treated cases with epilepsy. We've seen this over the years, and I treated a small cohort of patients at Stanford with intractable depression, an area of the brain called Brodmann 25. These are small, highly accurate targets that need to be treated, surrounded by the most elegant, eloquent anatomy. Here we have the nucleus accumbens with addiction, which is going to be our first primary target. So what we've been able to show now in a series of, I'm not going to show you the basic science here, but having worked on this for the last 5 to 10 years, we now in a series of pigs can show that with a certain threshold dose, you first get activation, and as the dose goes up, you start getting inhibition, and then finally you go to cell death. So you have really a switch, a thermostat with radiation that can gradually alter the sensitivity of a circuit from up to down. And we're proposing that in fact, may be where the next great frontier of radiosurgery is. And that's even more reason why you need a specialized tool that lets you treat ever smaller targets and ever more sensitive areas of the brain. So as important as BRAINMETS are, especially for this community here, there is even a bigger problem out there for radiosurgery to solve in the future, and why we're enthusiastic about why we need ever better technologies. So this is some of the creatures that we're starting to treat now with. We've been working with pigs in Aarhus University in Denmark, but also in Taiwan. So here's a pig, one of our early victims. So this pig, a happy pig, we think, has some toys to play with, water, you drink, eat food, actually chase female pigs. But no, this pig was now an alcoholic. Watch this pig. So this pig, as you can see, had one too many drinks. This pig is just all he's been is likes to drink alcohol. So this pig is stumbling around. All he wants to do is drink more alcohol. So here's an example of addiction. And this is who we're starting to treat now in National Taiwan University, trying to downregulate the nucleus accumbens so that he changes this behavior. So now, once again, engage in life, as so many addicts have stopped engaging in life. So we're starting a clinical trial in China in the next year to try to treat addiction with this new radiosurgical paradigm, neuroradiomodulation. So that's where radiosurgery has been. This is where it is today, and this is where it's going. And it's been a privilege to be part of this meeting. Thank you for listening to me.
The physician from Norway asks you if there is a maximum number or tumor volume that limit Zapix treatment.
The honest answer is we don't know. So the outcome with brain metastasis is heavily influenced by tumor number and tumor volume. What I can say is that wherever that limit is, the ZapX will let you push the limit to the greatest extent. So it's going to take time before we know this, but by having this proverbial sharper knife, you can treat more tumors in more delicate locations who are bigger in volume than you could previously. But where that threshold is, we do not know. So.
Okay. And in our institution, we have a CyberKnife device, and
I love it.
Yeah. Okay. As you know, we can treat the brain, the spine, and other tissue with the Zapix. You can treat the brain. Where can you get?
Just to the base of the neck. So no, it's a different tool. And if you want to treat a spine, then you're going to have access to a CyberKnife or varying machine or something else. This is not a solution for everybody, but for those people who treat a lot of brain metastasis, and that is the purpose of this meeting, it will be the best-in-class solution.
Okay. And yes, Manuel?
Whether the mechanisms that we are seeing are something related to cell death only, or there is something else. I mean, like...
It's totally something else. And so I could give a 2-hour lecture on that, but we have been studying it, and whether you're working in squid axons, the visual cortex, motor cortex, the hippocampus of rats, pigs, you see a change, particularly in interneuron activity. So an inhibition, initially an inhibition of interneurons, or an inhibition of inhibitory interneurons. So initially an activation, and then at greater doses you start to see an inhibition. So it's a very complex set of biology. And we're in France, where we invented radiation, right? We invented radiation here with Marie Curie. So we need to start thinking about radiation a very, very different way. But it's heavily influenced by volume and dose. So I can't do justice to it here, but I've written several papers on the subject, and if you send me an email, I'll direct you to these articles. And this is a new frontier. And if there's anybody in this audience who wants to participate in this new frontier, especially young people, I urge you, especially from a radiobiologic perspective, to investigate this. We're just starting to discover this new world of radiomodulation. It seems to be some of it in the squid axons seems to mediate through the potassium channels, for example, and the action potential.
Thank you.
Thank you, Phil. Thank you, everybody.
Good morning. It's my pleasure to be here. Well, virtually anyway. I wanted to thank the organizers for the really kind invitation to speak and their indulgence in letting me present virtually. Due to COVID-related travel restrictions, I'm not able to attend, and it really breaks my heart. Here are my disclosures. So as this audience really needs no introduction, leptomeningeal metastasis, or spread of cancer cells into the CSF-filled leptomeningeal space, occurs in about 4 to 8% of solid tumor patients. And while any tumor can really result in leptomeningeal metastasis, in modern practice, the major contributors are breast, lung, and melanoma. And unfortunately, as we're all aware, even with treatment, the prognosis for these patients is quite grim, with an overall survival on the order of about 3 to 4 months. Despite these statistics, there is a small silver lining, and that's illustrated here in A, the collection of spinal fluid. So part and parcel of diagnosis and management of these patients is collection of spinal fluid, and this really affords us an opportunity to understand the biology of this disease. So my role here today is to really focus on microenvironmental aspects of leptomeningeal metastasis. And so we're going to take a brief look here at the leptomeningeal space. So the leptomeninges are comprised of the pia and the arachnoid and contain the circulating cerebral spinal fluid. And of course, they surround the entire central nervous system. The spinal fluid itself is generated by the choroid plexi, which are structures that are located in the ventricular system. And the spinal fluid that they generate is profoundly unlike the serum found elsewhere in the body. While identical in terms of osmolarity, the CSF is different in almost every other aspect. It has lower pH, vastly lower oxygen tension, lactate pyruvate ratio is skewed. There are minimal amino acids, lipids, and iron, as we're going to talk about later. So this microenvironment poses some very real constraints on the growth of cancer cells within this space. But before we kind of address that head on, I wanted to focus on one aspect of leptomeningeal metastasis that will prove quite important, as you'll see. And this is this question of which aspect of the microenvironment these cells live in. Leptomeningeal metastases can grow either adherent to the surface of the pia or grow floating within the cerebrospinal fluid. One of my postdocs asked the pretty important question, are these two separate groups of cells? Do they exist in equilibrium with each other? What is the exact nature of the relationship between these adherent cells and these floating cells? So what Jan did is he took a look at our mouse models. He quantified the mouse models on the basis of immunohistochemistry and found that about 20% of the cells at any given time appeared to be floating within the leptomeningeal space, and about 80% of the cells were adherent to the surface of the brain. When we looked at our cells in culture, we found that very similar populations, about 20% of the cells were floating and about 80% of the cells were adherent. To address this issue of whether or not the cancer cells that are floating or adherent are existing in equilibrium or represent two distinct populations, Jan carried out subculture of the floating and adherent subpopulations serially and found that through this subculturing process, he was able to isolate a floating subculture of cells as well as an adherent subculture of cells. Of course, in either of these categories, we do see these are not pure subcultures, so there is an equilibrium, but we were able to enrich the two groups for either floating or adherent characteristics. Jan went ahead and characterized these extensively in culture, and I'd encourage you to read his paper. But importantly, what he did do is he then took these subpopulations and injected them back into mice. And we found that injecting the floating subpopulation of cancer cells accelerated the growth of these tumors, as you can see here in the middle panel of the bioluminescence. This is very different than the adherent subpopulation, which seemed to sort of kind of rest adherent to the meninges, but not do much else in terms of the mice. If we mix the floating and the adherent populations together 1-to-1, we get an intermediate phenotype, really suggesting that these floating cells in the spinal fluid represent the lethal subpopulation in leptomeningeal metastasis. And I bring this up because, of course, when we're collecting spinal fluid from our patients, we're collecting these floating cells. So it does then make sense for us to really focus quite a lot of our efforts on these floating cells. And we went ahead and did just that. We focused our first attempts at single-cell analysis on the cells that we collected from routine spinal taps. As you can see here in A, the routine collections of spinal fluid, when we take a look at the cellular composition of these, we find that the normally acellular or at least paucicellular spinal fluid becomes enriched in cells, specifically monocytes and lymphocytes, and the cancer cells really represent a minority population, about 10% of the cells. We worked closely with Dana Peer, our collaborator, to generate workflows that would allow us to make sure that these populations were accurately represented when the cells were analyzed on the 10X platform. And you can see here in B the results of this work. So this is single-cell RNA sequencing on the 10X platform of 5 patients with untreated leptomeningeal metastasis. 2 of these patients had breast cancer, 3 had lung cancer, and there were a total of about 15,000 cells. What's fascinating is despite the diversity of these samples, these are different patients with different primary tumors, the cells still clustered beautifully. Of course, the untransformed cells clustered quite well. You can see these monocyte macrophage populations in red and these T cell populations here in green. However, these golden colored cells, these are the cancer cells, and they still clustered quite neatly. So with this rich source of data in hand, we next ask the question, well, how are cancer cells able to live in this challenging microenvironment? How are they able to manage to create their biomass to overcome these metabolic constraints? So Yudan Chi, the postdoc who took on this project, she reasoned that we should really be focusing our efforts on the analyte in the spinal fluid that is the most different from the serum, really suggesting that this would be the strongest selective pressure on the system. And that analyte is iron. So if you look here at a table that I think we could all remember from graduate or medical school, the CSF is profoundly deficient in extracellular iron. So of course the null hypothesis here would just be that the cancer cells don't need iron. They're not, they're not iron deficient. So she next took a look at the hormone associated with iron deficiency and inflammation, which is hepcidin. And you can see here that by ELISA, hepcidin levels are elevated in the spinal fluid of patients harboring leptomeningeal metastasis. Interestingly, levels of the canonical iron transporter transferrin are equivalent between the 2 groups, and this really suggests that the cancer cells have found some other way to manage this problem of iron acquisition. So we went ahead and queried our data set for all of the genes that are associated with iron binding and iron transport, and these are illustrated here in A in this heat map. The genes are listed on the left, and the cancer cells and other cellular components of the spinal fluid are listed across the x-axis. And you can see that macrophage and monocytes and cancer cells all seem to have a distinct method of upregulation of different genes in order to be able to acquire iron. Interestingly, there were really only 2 genes that were expressed exclusively by cancer cells in this data set, and those genes were lipocalin-2, LCN2, and SLC22A17. And lipocalin-2 is an iron-binding protein, and SLC22A17 is a lipocalin-2 receptor. So this iron-binding and receptor pair seemed to be a very interesting target to investigate further. So I'll just remind you a little bit about lipocalin-2. It does come up in quite a lot of screening, so I think some people may be familiar with it. Lipocalin-2 was originally isolated, co-purifying from MMP9. It participates in nutritional immunity through siderophore function, its ability to bind iron that's been complexed by siderophores. In fact, it was originally called neutrophil gelatinase-associated lipocalin, or NGAL. What's really interesting about lipocalin is its high affinity, his extraordinarily high affinity for iron, as you can see here in this table, and that it's typically generated by neutrophils or macrophage and inflammatory processes. So we were a little confused as to why the cancer cells were expressing lipocalin-2 in our system, but the macrophage monocyte population was not. And so we went ahead and tried to confirm this in a variety of other more low-tech techniques. So I'm presenting those to you here. First, we took a look at some autopsy case studies by immunofluorescence, and you can appreciate here in both A and B, this is the same patient. Here's the cancer cells that are attached to the surface of the brain, filling that Virchow-Robin space, this nice triangular shape, as well as a cytospin from the CSF collected post-mortem on the same patient. And in both sets, you can appreciate that the cytokeratin positive population is the lipocalin-2 positive population, and that the IBA1 positive population, the macrophage population, that this population is lipocalin-2 negative. Of course, there are a variety of problems that may have occurred with autopsy, and so we went ahead and confirmed again, this time in freshly collected CSF from patients by flow cytometry. And the same pattern holds true here. The majority of the lipocalin-2 positive population is in the pan-cytokeratin positive cancer cell population and not in the CD45 positive leukocyte population. So to really understand the mechanistic implications of cancer cell upregulation of lipocalin-2, we turn to our mouse models. In our mouse models, we found that we again see influx of immune cells in the setting of leptomeningeal metastasis, as you can appreciate here, of multicolor flow cytometry of the spinal fluid from these mice. And because lipocalin-2 is a secreted molecule, we're able to carry out ELISAs. And we found that, similar to our patients, mice with leptomeningeal metastasis have elevated levels of lipocalin-2 in the spinal fluid compared to their counterparts with metastases elsewhere. And on by immunohistochemistry, we can also appreciate that the lipocalin-2 positive staining really is isolated to the areas of the brain with cancer cells on the surface. To address the mechanistic aspects of this, we knock down lipocalin-2 expression through the means of two independent short hairpins, and you can see that here in A. And we found that knocking down lipocalin-2 inhibited cancer cell growth within the leptomeningeal space and provided a survival benefit for the mice, as you can see here in B. To do the opposite experiment, we took cancer cells with no particular propensity to grow in the leptomeninges, our parental cell line, and we overexpressed lipocalin-2. Overexpressing lipocalin-2 really accelerated the growth of these cells within the leptomeningeal space, as well as the demise of the mice, as you can see here in E. What's pretty important to note, and really very interesting for us, is that lipocalin-2 does not appear to impact the growth kinetics of cancer cells within other anatomic sites. So you can see here in the lung or in the subcutaneous tissue or in the mammary fat pad, knocking down lipocalin-2 expression didn't really alter the growth of the cancer cells. So then what we're really interested in is how lipocalin-2 might alter the capacity of these cells to grow in the leptomeninges. Now we know that lipocalin-2 is downstream of a variety of inflammatory regulators, including NF-kappa B and STAT. So we queried our single cell data set and we found a pro-inflammatory signature in the macrophage population. It's this population here in the lower right. So to address this, we collected macrophage from either the spleen or the CSF of our mice in the presence or absence of leptomeningeal metastasis, and used this as a source of cytokines for our tumor cells. And we found that it was really just the macrophage collected from the spinal fluid of mice harboring leptomeningeal metastasis that were able to induce lipocalin-2 expression, as you can see there in C. To be able to identify which cytokine was most important for this process, we carried out immunodepletion experiments from human spinal fluid and found that the majority of the activity was really in IL-6 and IL-8 depleted spinal fluid. And of course, we did the inverse experiment, adding back recombinant interleukin-6 and interleukin-8 to artificial CSF to confirm these results. Looking closer at this macrophage population, we were curious to see if these were predominantly M1 or M2 polarized macrophage. And similar to other single-cell RNA sequencing of human tissues, we find these non-reciprocal gradients of M1 and M2 polarization, really indicating that there are no distinct populations that in human disease as we see in our mouse models. What was particularly interesting to me was in the diffusion pattern, the third component of that diffusion was really hypoxia and hypoxic signaling. So we set out to address this issue of hypoxia and its link to iron transport in our system. So as you can appreciate in A, at the level of the transcriptome, we see again this beautiful linkage between hypoxia and iron transport. What about a more functional aspects of this? To address this, you then cleverly generated a dual reporter system, N-Luke, which is downstream of a hypoxia-inducible element, and F-Luke, which is a constitutive system. Instilling these cells in the mice, she was able to demonstrate, as you can see here in B and E, that the cancer cells immediately encounter a hypoxic environment. And despite this, the cells are able to continue growing. And she was able to show this again through more traditional means of immunohistochemistry of lipocalin-2 coupled to HIF-2 and 1 But we need to get back to this question of iron, right? So in order to measure iron in the cell bodies of the cells in our system, we turned to Tiffany Thomas, a collaborator up at Columbia, who carried out some really beautiful induction-coupled mass spectrometry experiments. And Tiffany found that in the presence of leptomeningeal metastasis, cancer cells do have adequate iron stores in their cell bodies, but if we knock down either SLC22A17 or lipocalin-2, these stores are reduced. We can rescue these iron stores by overexpressing lipocalin-2 or by overexpressing transferrin. What was fascinating is that these changes in iron stores at the cellular level reflect what we see in the mouse. So you can see here in B that overexpressing transferrin rescued the lipocalin-2 knockdown in our in vivo model. What about the other cells in this system? As I showed you earlier, macrophages are upregulating all kinds of programs to access extracellular iron. What happens to macrophage in this system? So Tiffany Thomas assayed cellular iron levels from macrophage in our system, and she found that in the presence of leptomeningeal metastasis, CSF macrophage have lowered cellular iron stores. And if we knock down lipocalin-2 expression in the cancer cells, this alleviates this problem and the macrophage iron stores are restored. This loss of iron, cellular iron in the presence of leptomeningeal metastasis has real functional consequences for the macrophage, and you can appreciate that here in B and C in the form of reduced macrophage phagocytosis in B and reduced respiratory burst here in C. So because iron was demonstrably limiting in our system, we went ahead and treated the mice with an iron chelator, desferoxamine, intrathecally. As a control, we used penicillamine, which is a copper chelator. We found that chelating iron in the leptomeninges inhibited cancer cell growth in our mouse models, either as an early treatment or as a late treatment, and this was true in all of our models. So I hope I've convinced you of a model whereby the inflammatory signature of cytokines coming from the macrophage leads to expression of cancer cell lipocalin-2 and SLC22A17, and that this allows cancer cells to access extracellular iron, really outcompeting macrophage for this essential micronutrient, supporting the cancer cell growth, and leaving the macrophage unable to carry out their needed macrophage functions, including phagocytosis and respiratory burst. And so with that, I'd like to acknowledge, of course, the people who did all the work in my lab, as well as our wonderful collaborators and our really generous donors. But I'd really like to thank, most importantly, our patients and their families. They're really at the center of our work. They don't just inspire the work, they really are the engine that drives it. Thank you very much.
So very unfortunately, or not unfortunately, but it's 4 o'clock in the morning in New York, so Adrian is not with us, I'm afraid. So the next session is on challenges in clinical practice, spinal cord metastatic compression and intrinsic medullary tumors. And our first speaker will be Manfred Westphal, who already gave an excellent talk yesterday evening.
So we'll continue in a different compartment, and I think it's really a very good meeting, and I think these were excellent talks we had this morning. So I'm going to talk a little bit about an entity which is maybe neglected and may become more and more important in the future. I also found that I mixed up 2 slides, so I have to go back and forth at one point. So I'm not going to talk about, although Philippe gave me the topic on malignant cord compression as such, because this is a very typical situation which we very often face in clinical practice. These tumors are very complex, and it would fill a whole meeting to discuss what kind of surgery to do and what kind of stabilization and approaches and combined treatments. So these tumors that affect the spinal column, I will not talk about today. So I also just want to mention that all these tumors that we see there sometimes may have a very benign reason too. So there's also benign cord compression. There's not only malignant cord compression, but also benign cord compression, like in a case like this, where you can actually see that the bone here is not eroded, but it's actually sclerosed here, and this turns out to be just a normal benign schwannoma that can be taken out. So going to these spinal metastases that we as neurosurgeons very often are dealing with and consult with our neuro-oncologists and our radiation therapists, the ones that are intraspinal, they are either intramedullary or epidural. There are very few that are really on the surface of the spinal cord. So most intraspinal extramedullary, they are extradural. And not in the subdural space. And here again, you can see that this is a rather complex case that looks like as if there was a solitary cord compression here. But when you look at the bone, you see the bone is eroded. So this is a very complex infiltrating tumor, and it's extradural. Here's a rare case that we had in our series that is subdural. Supposedly, it could have also been a meningioma, but it's not. This is a very rare tumor. This is a melanocytoma. They occur there primarily also around the spinal cord. So this is sort of a semi-benign, semi-malignant cord compression. This can be cured actually by surgery. So, but this would be a rare case of a subdural tumor that is extramedullary. So this is really the issue that we are facing increasingly, that those are metastases of different kinds of tumors that occur in the spinal cord. So these are truly intramedullary tumors. And they still seem to be an uncommon entity, because this is from 2021, from this year, so there are still case reports coming out, and they're not in the highest impact journals, but there's still a lot of case reports because nobody really has big series. So it's still an entity that is quite rare. And nevertheless, it is an entity that is growing because patients live longer, and we have to acknowledge that the spinal cord is part of the CNS. So with the increasing number of brain metastases, we also see an increasing number of intramedullary tumors in this small compartment. In our series, it's only like 4% of patients that we saw with metastases. But vastly the most tumors that we see in the spinal cord are from different sources. And this is a topic that is, to me, quite unsatisfactory, because as you see
here, these tumors have extensive involvement of the spinal cord, causing edema, as intramedullary tumors that are there per se also do sometimes. But they are in various places. They're not really in the central cord. They can have very asymmetric symptoms, and they can be anywhere in the cord. So they're not really originating from the central canal as many of the others intrinsic intramedullary tumors do. So for those tumors, we have, of course, an individual approach. The life expectancy of these patients has to be considered for the indication for surgery, the tumor staging, the therapeutic options that are remaining. Then many of these tumors we can only debulk. And because we can only debulk them, they have a piecemeal resection. So because we can take them out in total, because they have very infiltrative edges, not like the intrinsic tumors of the spinal cord, most of them. So, and the extent of infiltration is highly variable on the location in the spinal cord and with the histology of the primary tumor. So very often these patients are followed with radiation, but the radiation oncologists know that the radiation doses that we can give to the spinal cord are different from what we can do in the brain. So the tumors very often occur late in the disease. Most often the histology is already known. These tumors or these patients, they are heavily pretreated. There are limited adjuvant therapies. Most of them have already been exhausted. In total surgery is impossible, and subdural is rare. I'm going to show you. So I'm going to briefly go to what I found useful in surgery for intramedullary tumors and show you why this is different for the tumors, for metastatic tumors. This would be renal cell carcinoma metastases. This would be for mammary carcinoma. They look like nice and circumscribed tumors, good surgical targets. This would be from small cell lung cancer. And this is a tumor that is an ependymoma. So there's not, when you look at the radiographs or the MRI images, they're very similar. But this is completely removed. And very often, this also an ependymoma, have a central cord incision, and then we can sort of just roll out these tumors. Patients are post-op, first or second day post-op, they're running around on the ward. So, and the technique there is that we have a midline approach, then we can go around the tumor. This is where the vascularization comes from. So we can sort of go around and circle it. In the ventral part, we really have to be very careful because could be also this anterior spinal artery. But this is a very predictive approach that you can do, and the tumor can be ruled out. And in the environment, we use a laser to dissect just in a very good dissection plane, and these tumors can be completely removed, even if they are very big. Like in a plastic tumor here, which was an ependymoma, and this is something you probably have not seen before. So this is already leptomeningeal spread, unfortunately, in this case because it was a malignant tumor. But here you can actually see through the spinal cord. It's opened, tumor is resected, and this is a ventral hole, and this is the ventral dura. So it's really a cord that is almost completely emptied, and the patient as well. And this was where I mixed the slides up. But this tumor recurred, unfortunately, and as you see here, she had to have radiation, and it didn't go much longer with her. Unfortunately, she died from disseminated disease. So to go to the intramedullary tumors that are metastatic, we have examples like this. It also looks nice, well circumscribed, much more inviting for surgery than the other case. But look at this. Here we have gadolinium enhancement, nodular enhancement around the spinal cord. And the spinal cord is almost completely filled with tumor. That's not the problem. But the problem is that this is the most extreme situation of infiltration. You see here the surface of the spinal cord with the distended veins. And here you see the nerve roots or the root exit zones or root entry zones, depending on whether it's dorsal or ventral. But you see here on the nerve exit zones on the surface, you see the tumor is sort of squeezed out of the spinal cord, like toothpaste. So this is really the prime example of why these tumors are very difficult to treat, because they're highly infiltrative. And as I already mentioned, subdural is rare because in the subdural space, these metastases very often get stuck in the chorda between the nerve roots when they are tumors, when they form tumors. So this is on the nerve root. This is leptomeningeal carcinomatosis. So this is really a very early stage of a tumor development. But when you look at this case, for example, we have here something that looks like a tumor that is globular, maybe removed. The patient is in greatest pain. But when you sort of play with the windows, you can already see that there's leptomeningeal involvement here. But this is a solid tumor. And we really thought that we could do something for the patient, but this tumor is completely stuck in the nerve roots there, so we could only do some wedge resection and scrape something out. This would be the optimal result. She had great pain relief, fortunately, but for the tumor removal, it's very unsatisfactory, unfortunately, with these cases. This is just a very simple hemilaminectomy, so the patient has no stability or mobility problems afterwards. And this is a prime example of what these look like. You see here, the tumor begins at the end of the cauda of the spinal cord, and then the nerve roots become increasingly encased in the tumor, and there the tumor ends. So they are completely like if you boil spaghetti and you put them in the dough and you bake them. So and you try to get the spaghettis out of the cake. It's impossible. So this is a short topic because we really don't have many big series, and I think the most important thing is for these tumors that they are late complication of cancer. They are very rarely can we remove them completely. The goal of surgical intervention is mostly the symptom relief for these cases, different from intrinsic intramedullary tumor. But what I think is important, because they are so rare, because we still see case reports, and because many people have in their clinical practice maybe 1, 2, or 3 patients a year, we should think about having registries for these, because we can learn more about those patients and maybe get a better handle on their prognosis, adjuvant therapies, because it's a very heterogeneous field. They're almost like individual cases, each of them. And if we have larger registries, I think we can go somewhere. And with that, I thank you for your attention. So
there's room for a few questions.
So thanks, Manfred, for this great talk. As we discussed last year, we were convinced that this topic is very important to discuss inside of this meeting, because as you said, we have to face this kind of condition more and more frequently. I would have just one question, a technique question. You know, in the dorsal spinal cord, where the spinal cord is less vascularized, it's more tough to remove the tumor. Do you systematically do an adjuvant treatment, radiotherapy treatment after surgery, especially in dorsal spinal cord?
Yes, well, every patient of these patients will be discussed in a specific tumor board, because we're in the cancer center, so we have specialized tumor boards. So if it's from memory, from lung, from renal, it will be discussed in the memory tumor board or in the lung tumor board. And there are always radiation therapists involved in the board, and most patients do have adjuvant radiation. But the radiation goes like to 35 gray, sometimes 40 gray, I think, but not beyond that, so not the 60 that we would have in the brain. So, but it is done. And for me, it's not so much the consideration of vascularization, because when we open the spinal cord regularly, we do a midline approach, and there you have it's almost like a zipper, so it's easily access the intramedullary compartment. For the metastases, it's more or less the problem that they may be sided, and that they may occur somewhere in fiber tracts and not in the area that for intrinsic tumors can be easily unzipped. So I think there the problem is much more the immediate dissection plane on the surface, and not so much the vascularization.
I was asking you that because in our multidisciplinary staff, when we have a patient with a dorsal spinal cord with postoperative clinical status with paresis, and if the medical oncologist tell us that he have a treatment, targeted therapy, immunotherapy, and a well-controlled systemic disease, we decide most of the time not to do adjuvant therapy after surgery. And I mean, as you say, we don't have a lot of cases, like 2-3 a year, so we can make any conclusion. But I mean, that's our experience.
Yeah. But for dorsal, you should not really have much paresis from the surgery because it's all ventral. The motor tracts are all ventral. So what people frequently complain about is dysesthesias when you have dorsally located tumors, or even neuropathic pain, which is sometimes very bad to treat. You have to use anti-epileptic drugs in high concentration sometimes for these patients.
Okay. Caroline.
Thank you very much. I'm Caroline Robert from Gustave Roussy, and I treat patients with melanoma. And so there are these patients who have these, among other metastases, some metastases that are located here, and then they are treated following our guidelines with systemic treatment, but we are confronted with some patients. They arrive to us because they have melanocytome or intra or paraspinal lesions that look like melanoma, but it has nothing to see with melanoma. They are usually not BRAF mutant, and so we don't know how to treat them. I don't think that anybody really knows, as you said. But I wanted to share 2 cases. We had a recent melanocytoma of the bulbar, and it has been irradiated. It has been several surgeries, and then there was a cystic component. It's quite classical with these lesions, and we really had to pray to our surgeon to try to go again because nothing was working. We had nothing systematically that could work. We tried temozolomide, and then finally, the only treatment that was very effective was anti-VEGF, because we thought that maybe because of the secretion, we could have an effect on the secretion, because it was not really the dense part that was proliferating, it was really the cystic part that was killing the patients. And it was very effective, but after 9 months of very good effect, with a decrease of the steroid that the patient was very dependent upon before, he had an hemorrhage and he died. So it could be due to anti-VEGF therapy, but he also had hemorrhages before. But I did not see any report using VEGF inhibitor in these cases. I wanted to share this case and to ask if anybody had any experience. And the other 2 cases that I wanted to report for these paraspinal lesions that look like melanoma, but the patients had no other melanoma, and really it was growing very slowly, and several surgeries, radiotherapy, and then it comes back, and the surgeon tells us, I cannot take everything out, you need to do something, but we don't know what to do. And what we recently did was to talk to our intervention radiologist, and they did, we had 2 cases. One was quite successful of electrochemotherapy, and I wanted to know if anybody of you also had this kind of experience, like going inside to electrochemotherapy like we do for skin tumors, for example. It's, we use bleomycin or platinum-derived compound.
I wouldn't be able to comment on that. We do have quite a few melanocytomas, and those that were resected have actually never come back. Like this case that I showed you, she's now like 15 years out, and she has not recurred. I also have one in the brainstem I have with me, but I didn't include it into this talk. A big at the medulla oblongata, a big tumor there. I think they are rather benign, the melanocytomas. And one just has to, in the old series, where people have reported about single non-melanoma associated intramedullary tumors that seem to be primary intramedullary melanoma, they may be melanocytoma because this histology has to be reevaluated with that. So, but what I find interesting is is that we don't see many melanoma metastases in the spinal cord yet, because they are very frequent, and the melanoma loves the brain, and it should also be in the spinal cord, but it's comparatively less than in the brain. There may be some kind of organ preference there, I think.
One more question.
Yes.
Manfred, there was no mention here of stereotactic radiosurgery in the spine. And it seems to me that this new era of image-guided radiation, especially the CyberKnife, there's no reason to treat the spinal cord any different than you would the brain. And if you do treat the spinal cord with the same principles that we use in whole brain radiotherapy, we know it's not going to work and it's just going to be injurious. So would like you to comment about stereotactic radiosurgery in the spinal cord, please, or have someone else on the panel.
No, maybe we should give the floor then to Frederick, because
but
that's what he's for.
Yeah, if he's referring to our series and our local practice, I can tell you that we do discuss that actually. But the question, the issue is that many radiation therapists do not have enough experience or not the equipment to do really highly focused stereotactic radiosurgery in the spine. And I think it's a question of getting used to it.
And hopefully we have
yes.
both
Yes.
experience and machine.
Yes, good.
That's what I like to hear. That's what I like
So,
to hear.
Frederick, you will fill in the void.
I do have
Thank
a
you,
lot of
Manfred.
experience, and so
Thank you.
It works well. Okay.
Frederick will update us on the possibilities of highly precise radiation therapy in the spine.
So first, we go after surgery, mainly. Interesting. Interesting. This is. So we skip that. So I think there are two subjects, very different ones. The spinal cord compression, intramedullary tumors. The first presentation is an urgency clinical presentation. Pain is at the first presentation, and I think for spinal cord compression, the first endpoint is functional one and pain. Then the endpoint, the less important, is local control. Survival is fully depending from the metastatic status. The intramedullary tumors are very different, mostly slowly evolving, deficits more than pain. Endpoint is not, for me, the local control. Is it roughly a chronic disease? And the endpoint, the most important one, I think, is quality of life. So it's clearly different presentation. So RT after surgery, yes, because of pain and pain relief, thanks to surgery and to surgeon. Sensitive problems, walking ability, it's independence. So it's very important in terms of quality of life. MRI, of course, more than CT. And radiation oncologists need neurosurgeon, especially for at least a diagnostic orientation. No histo, no radio. I think it's our first goal, not to irradiate nothing without any histology, and especially in our modern area of precision medicine. So for better functional results, we all know that for patients, if you evaluate the patient still ambulatory after treatment, if you take surgery then radiotherapy, it will be mostly better than radiotherapy alone. And if you select the patient among patients ambulatory before treatment, it is still the difference. It's also, and of course, retrospective series, but surgery first is rather to be preferred mostly. One of the debatable questions is about steroids. Yes, do we have to use very high dose of steroids after surgery, and during radiosurgery or radiotherapy? That's a debatable, actually. The other thing is that more and more, in many cases, the place of chemo and new drugs is more and more increasing. So, in terms of radiotherapy, and to answer, I think what a mess. And for non-radiotherapists, it's a question. Because we have many machines, many techniques, many fractionation, and it's not easy to clarify this question. We have Tomos, we have Linux, we have Cyber, we have Novalis and some very beautiful tools. We have different types of techniques. The 3D, very basic one, conformal radiotherapy, the IMRT with intensity modulated radiotherapy, and we have stereotactic radiotherapy, you're right. The fractionation, very different, depending on the site, on the machine, on the radiation therapist, and finally, depending on the patient and the patient presentation. You can deliver the 30 grain, 10 fractions in 2 weeks or 4 weeks. We have a very short one fraction of 8 gray. We have a very interesting 3 fractions of 10 gray, so only in stereotactic way, or 5 fractions of 6 gray in 1 week. So what a mess. To simplify, I propose you 3 different types of indication. The first one, very palliative one. So anterior, posterior, 3D, very old, but useful for the daily life. For some patients, especially pain patients, one fraction of 8 gray or 5 fractions of 4 gray, using very classical Linux. But you see that, for example, the anterior part of radiation is not at all a good thing. At the opposite, we have some patients with curative intent, especially with non-extra CNS evolution in terms of metastasis, in terms of disease. So you have to take all the time with the neuroradiologist, with the neurosurgeon, to define exactly what will be your target. Because the medulla is very, very contiguous to the target. So it's very important to have the best dose gradient as possible. And in this case, with the special machines, dedicated machines and dedicated teams with physics, physicians, and radiologists, you can deliver, for example, 5 fractions of 7 gray, even 3 fractions of 10 gray, for example, with the Cyber, in a very, very specific 1 vertebra level, for example, here. The other cases are intermediate, and you can use different machines and varying schedules also with Tomos or with dedicated Linux. It's possible. So it's an intermediate scenario. Finally, in terms of results, important, clinically speaking, to say that you have to evaluate, for example, the worsening, the motor worsening after radiotherapy, not only at 3 months, but also at 6 months. Because the subacute period after radiotherapy post-surgery is not, in my mind, at 3 months only, but we have to evaluate with a long, intermediate term evaluation. And the same for ambulatory after radiotherapy. A certain percentage of patients are ambulatory after 3 months, but if you wait a little, more patients will benefit from radiotherapy in these cases. So there are beautiful illustrations of this stereotactic radiotherapy. For example, renal cell carcinoma with a unique metastatic vertebra, differentiated thyroid cancer with no evolving disease extra CNS, but this is a very beautiful distribution of dosimetry also. So finally, the techniques. You have to choose the techniques for depending on the patient, and as usual, the higher survival the patient will be expected, the best techniques you have to take. For example, here, Rades especially published many papers on this subject, and the score permits to better select the patient for the more advanced technique, even proton therapy, for example. We don't deliver any proton therapy for this type of patients. So the top 5 conclusion for this type of spinal cord metastatic compression: always consider surgery, then evaluate expected survival, identify the clinical symptoms, choose wisely the best radiotherapy technique, and coordinate optimally with the surgeon and the medical oncologist. Before the questions, the second topic, intrinsic medullary tumors. So our background, and for example, in Gustave Roussy, we have rather 10 patients, or 1 per month, with real intrinsic medullary tumors versus 100 glioma patients per year, for example, at Gustave Roussy. Mostly slow evolution. They are referred from a neurosurgeon as a chronic disease, especially pilocytic astrocytomas, low-grade astrocytomas, ependymomas, and hopefully rarely higher-grade glioma, intrinsic medullary tumors. Some spinal location of midline gliomas, very important because it's a new and unique entity. So here is a very important place for medical oncologists. But finally, and I think it's the global answer, multidisciplinary challenge with surgery, radiotherapy, and systemic treatment, especially in this type of intrinsic medullary tumors. Very important. To answer to John Adler, in our RT field, I think, because I'm a basic radiation oncologist also, our key principles are not really applicable in intramedullary spinal tumors. Why? You know that the right dose within the right volume is not so easy intramedullary than intracranially. Brainstem, for example, maximum equivalent dose 54. We can't deliver 60 gray. Medulla oblongata, but it is a continuous anatomy, 50 gray maximum equivalent. Spinal cord, it's debatable, between 40, 45, depends on the volume, it depends on the fractionation, but we are limited. And for example, even for melanoma, even for ependymoma, the best dose radiation we have to deliver is always under the maximum dose possible on the spinal cord. So it is one of the problems. And if you say that with the best gradient, dose gradient as possible, it will be different. I would love that, but I'm not convinced with large series and long follow-up. That's the question for my patients. So the target, not so easy to define. The optimal efficacy toxicity ratio problems, especially for high-grade gliomas intramedullary. We can probably increase the progression-free survival. The survival, I'm not sure at all. We have to be very modest for that. Preventing or improving neurologic deficits, first surgery, then radiotherapy, but it is not so evident, especially because pseudoprogression, especially if kystic component, is very difficult, and mechanical answers are better than radiation therapy, in my point of view. And if you deliver more than 45 as 50 gray, for example, for a very small piece of medulla, and if the patient is a long survivor, he is, of course, more exposed to post-radiotherapy myelopathy. So that is, I think, the main slide, histomolecular subgroups, because these are very importantly dedicated to, if possible, so we need surgeon for that also, pilocytic astrocytomas are very different from diffuse astrocytomas, very different from high-grade astrocytomas, and finally, very different from midline gliomas. These are 4 entities, 4 subgroups, and for each subgroup, patient-by-patient discussion as a multidisciplinary staff will be, in my mind, the key. So, for example, this grade 2 ependymoma, slowly progressing, T1 gadolinium, this is the images, but with flare, this is the images. Are you sure that the real tumor is within the T1 gadolinium only, fully in the flare? Do we have to add some CTV, some microscopic extension? How much? I don't know exactly. And we are missing this type of very key information for us as radiation oncologists to better define the target. So finally, very classical radiotherapy plan, heterogeneous dose if you can. So the upper limit, it's possible to deliver 44, 45. The lower pole, we have to respect a maximum of 40 gray. So it's voluntary heterogeneous. Finally, Non-progressing at 4 years, okay, that's a good local control, but the patient at the daily life, he's still invalidated. So what would be exactly the clinical benefit? Case 2, it's a very young patient still in life now. The disease began very, very long time ago with very few symptoms, torticollis, headaches, stable in terms of image during many, many years, and the brain was okay for information. You see the detail of the location on the whole spinal axis. And it was ependymoma, myxoid, very, very classical, grade 1 classified. So our exploration was okay. So what are your options? Because the patient was only followed, then referred to us to make something. We decided to discuss with the patient on-demand focal radiotherapy, craniospinal radiotherapy, chemo during 1 year, or strict follow-up. After discussion with the patient, she asked for a strict follow-up, and during a very, very long time, you see, since 26, during a few years, 6 to 7 years, no progression at all. Then there was a clinical and radiologic progression, as you see. And the other spinal cord nodules were stable. So we discussed again with the patient, and about that, it was, we had the histology, so no surgery for that, and we proposed to the patient craniospinal radiation. She refused that. Focal radiotherapy, chemo 1 year. In a multidisciplinary staff, we proposed first-line radiotherapy. But it is really hard, because in final efficacy on toxicity ratio, we are very limited. You see that. These are the plan, RT plan, good tolerance overall, a better daily life, and now it's locally controlled. Just one problem, you see, and it's logical, thoracic progression, a new progressive progression on the location. So we deliver again radiotherapy on another site, 45 grade with tomo, because it's another location, another type of techniques, no stereo for that, of course, and it is locally controlled. Only one problem, above the other field irradiated, so it seems efficacious, but it's the whole spinal problem. Another and third location, very, very visible, so we asked for surgery, we asked before for surgery, it was refused by the surgeon, and focal radiotherapy was still delivered, and the patient is globally stable now, but in a wheelchair, and worsening day after day, but traveling. So the last case is the worst case. We'll be very brief. It was a high-grade glioblastoma-like intramedullary. And after a beautiful plan, radiotherapy plan, just a few weeks after the end, and some improvement, the patient dead with progressing imaging. So our take-home messages for that, if slowly evolving, take your time, try to enrich the molecular profile, sophisticated on-demand radiotherapy, integrating new drugs before, after, during, it's very debatable. Our efficacy toxicity ratio is a very narrow window. We have to weight RT doses and fractionation with caution, especially optimizing the timing of radiotherapy. Not too early, not too late. And pain relief team and planning radiotherapy with patients and proxies. Thank you.
Obviously, we would like Mr. Adler to give his first question.
You showed some very, very difficult cases to treat there at the end, and you know, when you're looking for a miracle, sometimes you have to use radiotherapy, right? But Manfred was showing some cases that are much more contained, and you in fact showed us some cases that are more retained, but you make it harder than it needs to be. So for you, the ependymoma is defined not by the gadolinium, but maybe by the flare. But for Manfred, he would decide that the ependymoma is decided by the gadolinium contrast and be very satisfied with the resection of the gadolinium contrast itself. So I think radiation oncologists overthink the treatment of the spinal cord because they're so horrified by complications. when you have a complication, spinal cord injury. It is one of the most devastating things for radiation oncologists, but in the process, they don't treat patients correctly, I'm going to argue. They're too afraid. So Hopewell has shown very elegantly over the last 20 years that the dose to the spinal cord, the spinal cord tolerance, depends on the length of the spinal cord being irradiated. And so radiation oncologists have just assumed the worst, that they're going to do hollow spine radiotherapy. But radiosurgery allows you to not treat the entire spinal cord. And in fact, many of the doses that you put up there, we routinely break at Stanford, routinely. When you're treating a hemangioparasitoma or a hemangioblastoma or a schwannoma or a juvenile polycytic tumor or an ependymoma. You can treat these tumors much more aggressively than you've applied, and you can treat them localized. The tumors that Manfred is taking out, yeah, most of the time we would take it out, but sometimes a patient's had a heart transplant. You don't want to take them to the operating room and you can do radiosurgery on it. So I think there is a lot more truth, clinical truth, between the stories you tell and the realities of radiotherapy and with what the world in which surgeons live in. And that's why I think this world needs a lot more communication. So anyway, that's a rhetorical statement, but you keep nodding your head, so I think you agree with some of the things I said, at least with spinal cord tolerance to radiation, for example.
So the youngest radiation therapists are pessimistic and you are optimistic. Okay, so you're right. We have to be, and to be still optimistic, but also realistic. So I need some large number of patients with a sufficient follow-up comparing exactly with the same patient, the high dose versus very classical dose. If you deliver me not only the experience of each radiation therapist for each patient, but a large number of patients published in a peer-reviewed paper, I will adopt that more largely because I have the machine, because I have the experience and many patients to treat. The second point is the number of patients will be very, very limited because of the rarity of the small volumes at the diagnosis. So I hope there will be more and more patients at this, but I present my clinical routine and not very rare patients, one per year.
But if we're talking about ependymomas, I think it's very important to clarify this here. In our large series of close to 200 intramedullary ependymomas, all those that were WHO grade 2 that were completely removed, there are 3 or 4 recurrences. So there are no radiation for any of these patients. It is very important, though, that to realize for anybody who would not go in and take these tumors out and prefer to go to radiation right away, which in some cases may be done somewhere, that there is a volume that is really determined by the contrast nodule. Sometimes they have a syringomyelia or a cystic component that goes 3 or 4 levels up and down, but you only have to remove the central core because that is just reactive gliosis that shows this rim of enhancement. There is not ependymoma. So if one would treat that whole area, that whole length with the radiation, one would overtreat like 80% of the volume that doesn't need to be retreated. But this is a discussion that really concerns ependymoma treatment and not really intermedullary metastases. But I just want to mention that.
Okay, thank you. Just before the question of Ricardo, one remark on the ependymoma. I was the reporter of the French database of ependymoma, so I treat 150 cases of ependymoma. Most of them, I mean, 73% were grade 2. And as said Manfred, in all cases with the grade 2 ependymoma, you can have a tumor control resecting only the contrast enhancement, never the cystic part or the hyper T2 or flare above the lesion. And there is very rarely a recurrence for this tumor. And the guidelines today in the literature is the surgical removal for grade 2 ependymoma. Ricardo.
So very briefly, as you know, myxopapillary ependymoma is more often a clinical issues in terms of management, because sometimes the surgeon is not able to remove completely. There are some mechanical skills into the CSF. So my question is, we have observed several times CSF spread, leptomeningeal spread, also in the cervical spinal cord. In asymptomatic patient, CSF is normal. So my question is, you will irradiate the spinal cord in this case of disseminated disease of a myxoid papillary ependymoma asymptomatic? I must say we did in the past without great results, not in terms of response or prognosis. And now, if the patient is not symptomatic, we do not treat, we follow carefully. Can you comment on that?
The answer was in the slide, I think so, that we respect the follow-up during several years before the clinical and radiological progression. The place of craniospinal irradiation as a prevention of other metastasis, or to better control that, provocatively speaking, it is still asked by our pediatric oncologists for their pediatric series of ependymomas, because it is more and more metastatic disease. And even for this very small age young patient, they ask, for example, for proton therapy, spinal cord irradiation, then a boost. But for adults, I agree completely with you. No place, definitive place for craniospinal irradiation.
Just one comment. When we did the review of all the French cases of ependymoma, I had a long discussion with Professor Figueret-Labrangier, and you have grade 3 ependymoma, grade 2 ependymoma, and the myxopapillary ependymoma. That's a peculiar histological entity and always localized at the end of the spinal cord. And for these cases that are benign tumor, if they are asymptomatic, we also opt for monitoring. And I have just one question for you, and we are running out of time. Do you sometime use radiosurgery for intramedullary metastases with edema and that are symptomatic patient?
I don't have the experience.
Up front?
No, I don't have the experience.
Okay.
So we move to the next session on the challenges in clinical practice, and now we will move to the world of cancer of unknown primaries.
Ricardo was probably one of the first neuro-oncologists who was interested in the topic of brain metastasis, involved in the very early clinical trials, and former president of EANO, and it's nice that you join us today.
Okay. Me too. I'm very happy to be here, that you have invited me, because the scientific level is always high as compared to the previous meeting we organized. But obviously the social part, I must say, which means to meet again a number of friends that we were obliged to see only on the screen, is very appealing, and I'm very happy. So I will focus on the clinical and management aspects of BRAINMETS from cancer of non-primary. Here you can see the outline, which is quite common. So starting from the definition, just to be clear, cancer of non-primary is defined as an histologically metastatic confirmed cancer for which clinicians are unable to identify a primary source after a diagnostic workup within a temporal interval which is more commonly within 2 to 3 months. The incidence of in general, brain mets from unknown account for 10–15% of the whole group of brain mets, and 18% is the incidence among brain mets as first manifestation of advanced cancer, which includes obviously the onset of a non-small cell lung cancer that is found during routinely workup. Just a general consideration, overall, the chance of identifying the primary site, we know more often in the lung, it's a non-small cell lung cancer, has improved over time due to improvement in imaging and histomolecular technique, and we will see some details. So very briefly, no major differences between BRAINMETS from unknown and known primary cancer. You can see here, nor in terms of age, gender, number of BRAINMETS, extra systemic disease. So diagnostic workup, very important. We have the ESMO guidelines that tell us that we need careful physical examination, some hematologic investigation, CT or MRI of chest, abdomen, pelvis, and extremely important, tissue for histological characterization and immunohistochemistry to look at some suggestion to find the primary tumor. For instance, I remember TTF1 is commonly used as an immunohistochemical marker because it relies to non-small cell lung cancer and the thyroid cancer, which is very rare, a source of brain mets. In the previous ANO guidelines, we recommended the whole body of PET for a staging in case of negative findings of the other investigation, and probably we were right, even if obviously the level of evidence of all these paper is low because the sample size is low, but we have now, you can see here, a number of paper. One is from Dr. Wolber from the Zurich group. Very nice indication that the addition of FDG-PET to the workup has improved the detection of the primary tumor, but even more importantly of the metastatic disease, the systemic metastatic disease, and this can allow a refinement of our prognosis assessment when you have to decide what to do. Prognostic factor, again, not surprisingly, prognostic factors of brain mets from unknown are not different from those of known primary tumors, so presence of extracranial disease, very important, age, performance status, location, number of brain mets. The same is true if you use some prognostic score, RPA in old ages, more recently JPA. Most series report a similar outcome at the end between brain mets from unknown and known primary tumor, but probably more recently, due to changes in diagnostic and treatment, we have some report of differences. I have chosen two examples. Longer survival has been reported for patients with late identification of primary tumor by the Vienna group, Matthias Preussers. Probably behind is the explanation that the primary tumor is not so aggressive. And there is some suggestion that patients with melanoma, brain mets from unknown primary, have a better prognosis. Probably this reflects the introduction of well-known target therapies in the melanoma setting. So here you can see this table from a recent review we have performed from Dr. Balestrino. All studies are retrospective. Here you have the studies of the last 15 years because the studies before are not evaluable with modern concepts. Obviously, there are still heterogeneity regarding the treatment, but if we look at the outcome, you see that overall median survival in most series ranges from 6 months to 1 year. With a rate of surviving patient at 1 year, which is up to 35% in the most represented series. Local control, obviously we cannot compare the results between whole brain radiation therapy and stereotactic radiosurgery. The only thing we can tell is that increasingly stereotactic radiosurgery is used. We used, for instance, in Torino. And there is some data suggesting that the response rate, the progression, the local control in general is a little bit higher with stereotactic radiosurgery as compared to whole brain radiation therapy. I think no doubt that the systemic progression definitely is higher than the intracranial progression. So what about what we call innovative treatments that basically are target agents? We must be careful because we have no clinical trial available. The evidence is very low in BRAINMETS from COOP. So at the end, most information come from case reports so far, but can be suggestive of some attitudes in designing clinical trials and in clinical practice. Here again, a table. Here we have summarized all the case report in which the authors have in some manner used an innovative approach. And interestingly, if you like, in some cases, the approach is a modern approach. So we have patients with multiple cerebral lesion, the histopathology, the biopsies, almost always, apart from melanoma, adenocarcinoma, in some cases suggesting non-small cell lung cancer origin, but it's obviously the workup was negative, and the authors look at molecular profiling, and they were able to identify some mutations, you can see here, and they used the target agent specific for the mutation. And if you see here, in some cases, they had great responses and long-term survival. So the same is true, for instance, for these cases of leptomeningeal metastasis and metastasis in the spinal cord. Again, they looked at molecular profiling, and in particular, they see high expression of HER2. Also, the liquid biopsy in the CSF confirmed the presence of HER2. They treated accordingly the patient, and the patient survived more than 2 years. Obviously, these are suggestions. And here you can see the list of the clinical trials on cancer of unknown primary that include brain metastasis. And you can see here that most of these trials are phase 2 trial, either randomized or single arm. The inclusion for COOP are the same of the ESMO guidelines, obviously, so diagnostic workup who is negative is requested, obviously. But if you look at the BRAINMETS inclusion criteria, you can see that not differently from most past trials on BRAINMETS from known, patients with BRAINMETS are accepted whether asymptomatic or previously treated successfully with a local treatment, whatever surgery or radiosurgery. Same trials. If we look at the intervention, you can see here 2 types of approaches so far in clinical trials. The first one is, which I think it's very interesting in general, is that the choice of the investigational arm, which is a target treatment, is based on the molecular profiling. And in this phase 3 trial, the comparison is conventional cytotoxic chemotherapy using agents that are commonly used in non-small cell lung cancer. And the same is true. The other ones are immunotherapy trial looking at the value of checkpoint inhibitors, in which obviously the selection is to have, the criteria of selection are different, but the threshold of PD-L1 expression is generally more than 1. We all know that there is a great debate on the role of PD-L1, but anyway, this is what the trial are exploring. Primary endpoint, either progression-free survival or response rate, all based on RECIST criteria. Only 1 or 2 of these trials have added the RANO criteria for the cohort of BRAINMETS. I must say that this is one of the limitations of this trial for our interest, because most trials did not think about a subgroup analysis prospectively of the brain metastasis among the other groups. But anyway, this is what we have on the market. So what about coming back to the practice, usefulness of surveillance over time, when after treatment, whatever treatment you have chosen? Allora, I have compared to ERA, before target therapies, after target therapies. 20 years ago, our group published a paper looking at the value of a systemic staging during the follow-up with serial CT, and we discovered at that time probably more primary tumor in general in the lung than without any staging. But this did not improve the overall survival. In fact, if you look at some other papers of this 20 years ago, all authors agree that it is not so useful to look at the primary tumor appearance during the follow-up because the prognosis is the same. So after target therapies, I think we can refine our approach. Systemic staging with CT and FDG PET may increase. You have seen the discovery of the primary tumor, special light appearances, and obviously we may have in these patients some druggable molecular alteration. So allowing to hope for some improvement of prognosis. So I think all these are suggestions, because if we look at at clinical trials, whether this precision approach yields a survival benefit is not clear. These are two trial published on this issue in Annals of Oncology, in which they performed site-specific therapy-based microarray profiling, but they did not find any improvement in survival, and obviously the costs are higher. Another point, which is probably again linked to what I said before, patients with melanoma brain mets from unknown primary may display superior responses to immunotherapy. There are some suggestions, but again, this reflects the happy situation of melanoma, where we have a number of therapeutic options to employ. So, I have spare time. Take-home message. Yeah, just it's a flash communication. What is important is the message, not really some specificity. So, take-home message, which means that based on the literature, our experience, and so the level of evidence of this consideration, I must say, could be level 5, which is not in general grading, but I put 5, maybe 5A, but not more. Okay. And so with multimodal therapy, patients with brain mets from COOP may achieve long-term survival. This is a common experience. The most brain mets from unknown can be resected completely, as the other brain metastasis. We treat them differently, we know. We do not use whole brain radiation therapy anymore. We use stereotactic radiosurgery post-surgery, with some doubt on using preoperatively, but anyway. Systemic surveillance, including FDG PET, is beneficial, obviously. We need to be aware, this was an approach in the nice paper from Zurich, that the PET with FDG systemically has some problems of specificity. So we must very carefully in interpreting the images, because sometimes in our experience we had some hot spots, for instance, in the lung, but these were related to some inflammatory problem, or in the colon, where some polyps or some other benign lesion can be active on FDG PET. Just to spare to the patient to very unpleasant investigation. So molecular workup. Again, I agree with Max. Increasingly molecular workup and diagnosis, which means molecular profiling, whatever you want to use, it will be in the future of increasing importance, because in individual patients we have data that the administration of personalized treatment can improve the outcome significantly, independently of a large clinical trial. And I must say that for me it has been very important to be invited to look at this problem, because after looking at the literature and the discussion, we set a meeting with our neuropathologist, and so we reach an agreement that in any case of brain mets from unknown primary, which is not so frequent, we now perform NGS to look at, we have some druggable alteration. And last, maybe, this was suggested by the Viennese friends, but GPA may help to select and stratify patients for clinical trials. Because if we remember the first table, looking at the survival data, they demonstrated that the best prognostic patient, which means GPA +1, has a median survival of 46 months against 7 months, 5 months, 10 months of the other ones. So obviously this could be useful also in clinical practice, not only in the clinical trials. I think, yes, close. Thank you very much.
Thank you, Ricardo. I think it has become clear that you like to travel again. That was very obvious. Maybe just one comment. I mean, I think
until the physical condition will be kept, why not?
Yeah. So you mentioned in the end the limitation of our study in Zurich, and I think it's really important with the unspecific findings, because we had several patients that on the FDG pad suddenly have 3 lesions, and you tell them first we take skin, then we take colon. If that doesn't work, we take your lung. So I think there's also some discomfort we produce, and I can only reconfirm for us the colon lesions that was where most often we went and we didn't find anything useful.
The same for us, but the patient was not happy afterwards. So I learned from the non-happiness of the patient some things. No, I think coming back to the paper at Zurich, what according to me is very important is that the FDG PET can reveal the true tumor burden systemically, which is very important to decide the aggressive and not treat and the prognostic, basically, and to refine the GPA if you like the GPA. This is the main message. I must say that there is some discussions regarding what is the best molecular approach at diagnosis, because obviously now there is the tendency to use NGS technique. Some studies looked at individual mutations. If you have seen the first case of multiple cerebral metastasis, adenocarcinoma, TTF1 positive, they looked at the most frequent mutation in non-small cell lung cancer, which is the deletion of the exon 19. They treat the patient with erlotinib. They failed. They came back to NGS. They discovered a resistant mutation, and they treated the patient with osimertinib, with the specific inhibitor, and the patient responded for 2 years.
So, Ricardo, I think that speaks to, the 2001 paper of Roberta Ruda, where we all realized that we should not be looking at the primary tumor, but looking at treatable primary tumors. And that's, I think, the whole point. You can find out a thing which is a primary very rarely happening, and we don't have systemic options, and then the whole point is mute. So that's where NGS comes in, because most of those cases were either from Tractus digestivus tumors, colon tumors, or lung tumors. And here we have the possibility of targeted treatments. So NGS should be part of the workup, that's without doubt, and I really question the usefulness of going with a PET beyond the CT scan. You can better spend your money on the NGS, I think, than on the PET, because I think it will give you more of a treatment leverage with NGS. And then, of course, you have the few melanoma cases, but I think most of the times the pathologists will identify those. So NGS should be part of standard of care of cancer of unknown primaries metastasized to the brain.
Yeah, if you look at, I completely agree. Practically speaking, in at least 80% of cases of brain mets for unknown primary, we know that this will be a non-small cell lung cancer. And then it's extremely important now to have druggable pathways to be treated, because the standard chemotherapy doesn't work. I remember at the time of Ruda paper, as we used a scheme of platinum compound, gemcitabine, no effect on the brain prevention of the brain regrowth, and probably no prevention of the primary tumor. So things have completely changed. And also time has changed, because Dr. Ruda, who was with me, now is moved in another institution to chair neurology and neuro-oncology. So luckily he had some career from, it was
based on that paper.
It was predictive, this paper. But the funny thing is that the paper was in a very, very mild level journal of neurology, which now we know that if you have a very poor paper, you can send to journal of neurology. But at that time, it was one of the, apart from neurology, one of the best journals.
Other questions or comments? Maybe then, Ricardo, before we go to the coffee break, a last question to you. I mean, you have really prepared your homework well. You found all these trials on the CUPs, but to me that...
And look at.
Yeah. But for me, it's...
Not only the title.
Does it make a lot of sense? I mean, I think it's almost a conflict. If you open a trial on CUP patients, you stop doing NGS, so you can put more patients on the trial, because I think in general practice, we would now do almost everything to transform a CUP into a non-CUP, right?
Sure. Sure. Yeah, last comment. I think that following what, I don't remember, Manfred that told regarding intermedullary tumors, maybe we can think about within this network, maybe to implement some registry, some observational studies on what we do with our CUP, with agreement to have the same molecular investigation to see whether we can have some more contribution. Obviously, frankly speaking, so far, modernly, the number of patients truly with brain mets from unknown primary is now around not more than 5%, probably, at most.